Good morning. Hello, everybody. Good morning in the US. Good afternoon in India. Good night in China. People are beginning to join from different parts of the world. So welcome and thanks for participating. My name is Matias Costa. I'm a cerebral vascular fellow at the Swedish Neurosciences Institute here in Seattle, Washington. I want to thank the Seattle Science Foundation for providing a platform for this webinar and for the help putting this together. This is our sixth cerebral vascular questions and answers session, and we have a very special guest today. Professor Pedro Lylyk is a neurosurgeon, director and CEO of Aneurysm and Clínica Sagrada Familia in Buenos Aires, Argentina. Among his extensive academic background, he's the chair of neurosurgery and hemodynamics at the University of Buenos Aires. He's a professor at the University of El Salvador and professor of endovascular surgery at the University of Business Sciences. After his neurosurgical residency, he did a fellowship in the endovascular neurosurgery at the University Hospital of London in Canada, and then UCSF in California. His endovascular lab is one of the training centers for fellows internationally, which has allowed the training of more than 70 professionals since 1995. Since the 86, he's dedicated to the development and improvement of devices and new therapeutic options to push the whole field of endovascular neurosurgery forward. And he's a worldwide reference in either academics and medical device industry. He was recognized as the first person to place an intracranial stent in 1996. And as of then, he has performed more than 8,000 brain aneurysms and more than 9,000 EVMs at his center in Buenos Aires. He also has developed this endovascular training and interventional radiology training at Aneurysm and Clínica Sagrada Familia for the benefit of physicians from all over the world. Professor Lylyk, it's an honor for us to have you today, and welcome. So you can share your screen.
Thank you, Matias. It's a pleasure to be with you, with somebody around the world with this new normality after COVID. It's really a pleasure. So if I can share my my screen, I will. Probably you see much better. So this is my disclosure. Today, it's a pleasure for me. It's a privilege to speak about the flow diversion. It has been dedicated my last 15 years of my life on flow diversion. You know, when we start, many few centers around the world were practicing interventional neuroradiology or endovascular neurosurgery or whatever you want to call. But thanks to many people around the world, some neurosurgeons, some interventional neuroradiologists, some neurologists, the field has exploded. You know, a lot of human creativity skill, a lot of imagination, combining with the systematic study of the structure and behavior of the human behavior. So some groups have some visions before. Back in 1995, A.J. Wakalo and the group of Baruch Leiber from Lylyk, Nelson Hopkins, they envisioned that maybe vascular stent will be an alternative in the future for the treatment for broad-based aneurysm. And after that, Baruch Leiber published that beautiful alteration of hemodynamics and models that set everything set the place for interventional neuroradiology and flow diversion. I will show you in the next minute our experience in Buenos Aires and our international center. Of course, everybody knows that we have two options today. We can treat those huge, I call complex aneurysms by endovascular or by surgery. Certainly, you will see some numbers. We have done quite a few intracranial aneurysms by endovascular means in Buenos Aires. It took us a while to reach 200 strokes per year treated endovascularly, but even today, we treat around 35 aneurysms per month endovascularly in Buenos Aires. So the curve of flow diversion raised progressively during the years. I have to acknowledge to all my team, neurologists, endovascular guys, cardiologists, that we're working together since many years, but especially all my fellows from Latin America. They have been working hard with us during those 15 years in flow diversion. And you see there are people from everywhere. There are people from China, people from India, but mainly from Latin America. So I really must be grateful to all of them. They did a big effort in Buenos Aires. Today, I would like to go with you over the little bit of history, comprehensive history of aneurysm treatment and flow diversion in the next minute. So once in a while, we have some kind of revolution, you know, the name, what is that? It's just a change of improvement. I think with the flow diversion, we improve the efficacy of endovascular treatment of brain aneurysm. So for me was kind of a revolution. What that happens? Well, that happens when there is a need. There is a need for something, you understand the problem, and somebody has the vision and comes with a possible solution. So the formation, the growth, and the rupture of the aneurysm is not an easy thing to understand. It's a complex problem, many variables there. But you know, when you understand the internal conditions, which are very important for us, like endovascular neurosurgeons, or the external conditions, which are important for microsurgery, we know a lot about that. But what do we know about the wall? I mean, we're sharing the problems with the wall. So the wall is really something that we have to understand, and probably is the next frontier for us. There are many aneurysms, many sizes, many morphologies, and we have to find a solution for each of that. We start our Stent way back in 1996. There was a dissecting pica aneurysm that I implanted the angio stent, which was a coronary stent at that time. I was able to insert some coils through it, and the patient went very well. So we use a stent like a key tool to make some difficult aneurysm treatment by endovascular means. Some of those potential treatment with the stent and the full diversion becomes treatable today. And that way we started at the University of Geneva, 2003, with Professor Rufenach at that time. Many people have been involved on that. I remember very well Kim Nelson at that time there, Olaf Blood, Makoto Ota. So many people, that was clearly an international effort trying to understand. What we were looking for? Well, everybody knows about the focal defect. There's a small defect, but what will happen if you have a segmental defect like this one? What are you going to do? Well, what is the focal defect? Is a small damage of the arterial wall, less than a quarter of the arterial wall. But what about if you have a segmental defect? If you have a segmental defect with the damage of the artery that involves more than a quarter or the same distance of length, you need to reconstruct the artery. And everything will change. For the small focal defect, you can clip it, you can do several techniques by endovascular means like coils, polymer, intrasaccular devices. But for segmental defect, we favor clearly the flow diverters today, after we went through stent coils, some neck bridge, and other ones. Those gentlemen, Kim Nelson and Aaron Berry, came around 2001, 2002 with the ideas after the neuroform development. And I really was impressed. They came from the concept and they made it possible with some prototypes at that time. What they were proposed? Well, just to do a reconstruction. It's like you have to go from normal to normal and forget about that segmental defect. So you must implant something to reconstruct the artery. Doing flow diversion, I prefer to call that flow modulation. I will show you that probably you know that you can really today move around the water fountains and see difference on flow. Well, I show you a case with a lady in her 50s. She was treated, she has a contralateral right aneurysm that was clipped, and she has a left ACA segmental disease with 4 aneurysms. The proximal one, the ophthalmic artery arises from the neck. what will happen if you just insert one single device. This is the contralateral clip there. And as you see, at that time, everyone went away except the proximal one because the flow goes through it and make a channel inside. If you have a patient and you wait a little bit, you will see 20 months follow-up, 6-year follow-up, like it shrinks, but the ophthalmic remain open. So that's, for me, is a flow modulation. This is a basic concept that we have to understand what we do in those techniques. What we aiming to? Well, we're aiming to have a circulatory exclusion for the segmental defect. How we do that? Well, we have to have a thrombus formation, we have to organize the thrombus, and we have some collagen to help us to do that kind of circulatory exclusion. That was very nice show by Giuseppe Lancino and his group on pipeline, but also that was shown with Cardiatis group and Surpass group. So how you have a maturation of the flow and nice reconstruction of the wall. We took advantage for a single thing that happened during those 15 years. A lot of things happened. We see much better. We have new tools, but especially when they understood the problem, the bioinformatics, the CFD applied to clinical setting help us a lot. And of course, we got the benefit of the translational research during those years. So this is some of the devices that we can see today directly inside. I mean, going from coils, from intrasaccular to endoluminal. You can see almost everything today. You can understand many things today. This is Juan Sebral. This is another Argentinian, Matias. He's at Juan Sebral. Juan is is assistant professor at Mason. Thanks to Juan, we understood a lot of things. We understood that we have to cover more than 90% of the ostium of the perforator to occlude the perforators. So we share with him a lot of fun and a lot of understanding. In that trip and that journey, we went from coiling to flow diversion. Today, some also flow disruption in those years. Well, the only thing that we don't forget is we have to think in terms of patients, not in terms of devices or in terms of sizing or morphology. The most important thing is the patient. Today, the flow diversion for us is the first option for unruptured aneurysm. It's not clearly an option for ruptured aneurysm. It's our last resort, but it's the first option for unruptured aneurysm. So many things, as I explained before, happened during those years. In yellow, some of those devices that we tried to develop or we helped to develop in Buenos Aires during those years in that journey. Starting with indication, what were the indications at the beginning? Well, we were treating wide neck aneurysm, mainly large and giant, some fusiform dissecting. Also, we treat some recanalized aneurysm with clips or coils. What did we learn? Well, was a tough learning. We learned a lot. We learned that we can have a complication too, early or late complication. We can have also thromboembolic complication due to the gelling or due to telescoping device in device or due to some stenosis. But we learned mainly that we were very safe. I will show you the numbers. Not only that, we were very efficacious. I mean, around 90% of those aneurysms healing and cure. And today we have a long-term follow-up to show you. Also, we learned that we do a lot of hemodynamic changes. I mean, and that will change over the time. That particular supraclavian aneurysm, this is before, 10 days after. You see how the thrombus is progressing inside. 9 months after, you see the anterior circulation was taken over by the contralateral one. And almost 3 years after, everything came back to a normal. That's proximal, but what happened more distally? This is one of the few cases that they did in the rupture stage and the ECOM. You see 2 years again, 2 years and a half after, you see the diminution of the caliber, but the artery, even if you cross the contralateral one, it still remain open. In the meantime, we got a lot of help. new devices comes to get better treatment. We had more and more clinical experience. We had some improvements of the delivery system and lengths. We have a longer than 20 millimeters. Remember, at the beginning, we have only the longest was 20 millimeters available. We can reship the devices. And another thing that I hope I show you. So we have divided our experience and generation. The first generation is something that all of us has been done: telescope, neuroform, and neuroform, enterprise and enterprise. That was the first generation of flow diversion for me. Second generation was a revolution with the pipeline. Seal comes right after and surpass. The third generation, Cardiatis and Fred. And the fourth generation was a lot of them. Multilayer, fully retrievable. For me, the fifth generation are very small devices and also with a kind of surface treatment. I show you our global experience today. We have treated a little bit more than 2,000 people with flow diverter in Buenos Aires, using a little bit more than 2,500 devices in total. So this is some of the devices that we have been using. Mainly, I must tell you, the chromocobaltium device by Pipeline, which is a fantastic device. So this is the first generation. The dissecting P1, you just telescope neuroform and neuroform. 8 months after, you have that beautiful result with a normal appearance of the artery. Pipeline came at the time the company was called Covidian. This is the second generation, and over the time you see almost 9 years follow up. The disappearance of the aneurysm. As I said in the beginning, we start around the 2000. Our experience, 2005, we were full devoted to animal lab in Buenos Aires. We did many pigs, many rabbits. 2006, we implanted our first case. 27 at 7, we were part of the PHENOX study. 2010, we had 230 patients treated with pipeline. We published our first bleeding complication here in 2011. PUF trial was done. We started in 2013. Flex and Shield comes later on. So at the beginning of our experience, like anybody else, we start with multiple devices. Kim Nelson was with us. We strongly believe that we have to bridge as much as we can at that time. We work in very proximal cavernous sinus. With the time being, we had a registry called AVRT. We prefer using more single devices, but we went a little bit more deep. We went distal, A1, A2, M2, PICA. So that was our experience. That was our first paper that was published 2009 on that. Today, the last paper is our experience with the original registry that we did since at that time, and it's called today Pedestrian. That was published with our first 1,000 aneurysms treated with pipeline only. Well, probably that series deserve a place in between here, in between those trials. 87% of that series has a angiographic follow-up, and after 5 years, the rate of permanent occlusion is more than 96%. So that was our experience. I will show you some demographic, of course, more female, lot of comorbidities, more than 57% of our patients has some kind of comorbidities, and 35% of those were large or giant aneurysm. Regarding the comparison of the outcome, if you compare PUF with our series, at the beginning we had only approaching 70% of total occlusion, but then at the very end, at more than 5 years, as well as PUF, we have more than 95% of occlusion. Regarding the complication rate, as well as PAF, we are below 5% of morbid mortality in our hands. So that was an interesting experience. Inside of the group, we have 80 patients treated with PET shield in the same registry, but the total number of shield, we have 274 patients treated with shield. If you compare pediatric with shield, we have less complication in our shield subgroup, a little bit less than 3%. At multivariate analysis, the age and non-sacral morphology were independent predictors of worsening on ranking, the modified ranking scale. And with shield, we have less thromboembolic complication, as you can see here. But I must warn you that we switched clopidogrel to prasugrel 5 years ago. So systematically, we are using prasugrel instead of clopidogrel. So it's also some conclusion in our experience with pedestrian. I think the intracranial treatment with pipeline has been shown is safe and is very efficacy over the time. Let me share some of the cases with you. This is the first case that we did in Buenos Aires many years ago. The patient was treated elsewhere with coils, and then was recanalized. The patient has also AVM. We treat both. We treat with pipeline the proximal aneurysm, and we occlude the AVM. Those are the controls post-treatment. And I believe I have 6 years follow-up, showing nice reconstruction of the artery. But the most important thing, showing also the healing line. You know, we were dreaming with that kind of healing line during our biological stage of the treatment of aneurysm. Here you see very clearly how the coils are separated from the aneurysm, and the aneurysm is really reconstructed at the time. So what about long-term follow-ups? What do you mean by long-term follow-ups? You know, we have been doing a lot of validation with long-term follow-ups. So this is a 7 years follow-up with a proximal one, with the PET, with the single PET. This is another 9-year follow-up. Proximal target. This is a little bit more distal, again 9 years. But the correlation between the angio was very nice, correlated with clinical and also with neuroradiological follow-up with MRI. You see the shrinkage of the aneurysm. That is that patient. How many implants can we do in different settings of the aneurysm? Well, this is a bilateral cavernous sinus aneurysm, and also patient has a dissecting right vert aneurysm that was implanted, and you see the control 6 years after, showing complete occlusion of 3 of them. So what kind of aneurysm we start to treat? Mainly complex aneurysm, giant aneurysm, going from proximal to distal. This is one of the distal that we already published. You see the ACOM aneurysm is partially thrombosed. You see the massive effect of the aneurysm, and you see what happened after 1 year. You see the diminish of the mass effect is clearly less, and is less than 7 years. What happened with the device? Well, you see what happened with the device. This was immediately post-treatment. This is 1 year follow-up and 7 year follow-up. You see the straightening of the device at the PL surface. So other complex aneurysm that we treat was fusiform, dissecting, some blister-like, but this is a clear example. Again, a very massive mass effect. You see the contralateral artery is occluded. We try to reopen it. We try to recanalize. With the wall stent was impossible to recanalize. It's a giant hypophyseal aneurysm with severe stenosis of A1, the contralateral one. So what are the limitations in those cases? The limitations are the access, one first, and the second, the exit. to find the exit. Many techniques have been developed by using balloons, using stents, distally, proximally, even some intrasacculous balloon to get support to went out. So this was our case. Really, the most difficult things was to find an exit. We treat everything. We did 360 loop. We tried with small cutters at the beginning. We ended up using Marksman, the 27 Marksman, and I succeed to using 2 wires. One wire I implanted at MCA, the contralateral side, another at ACA, to give me more support. As you see, in that work, we have some vasospasm on the right side, right MCA. So we start from distally, from distal to proximal, implanted 3 pipeline. The first one for 425 by 14. After a little bit more longs, as you see, until we reconstruct. As soon as the vasospasm went away, MCA from the right side was really back, and you will see what happened 4 months after that. There is some very small portion remaining, but you see the mass effect is much better at 4 months, and at 1 year we got complete reconstruction of that very ugly aneurysm. Of course, if you have a dissecting aneurysm, the pipeline works very well. This is right MCA giant dissecting aneurysm that was crossed with two pipeline. This is 7 months follow-up showing nice and complete reconstruction and shrinkage of the aneurysm on MRI. The transient stent stenosis was a big deal at the beginning. Everybody was worried about, especially because we were using at that time several multiple implants instead of one. But in our experience, it's less than 7%. We have, I think I can recall probably 2 or 3 that I had to angioplasty in my experience. It's something that happened between 3 and 6 months. Keep on anti-platelets, and the patient and it will go away. At least in our experience. This is another giant aneurysm that we treated. You see in T2 and in T1 the mass effect before the treatment, 1 year after the treatment, the release of mass effect, which is very nice correlated with angiography, as you see here. And the most important, she was completely cured as she went back to dance at that time. It's clearly the flow diverter is not a device for bifurcation. We didn't favor to use bifurcation as well for hemorrhagic cases. But once in a while, we had to use in some bifurcation. I'll show you one case that left MCA was ruptured. We treated with coil, recanalized, and we implanted a pipeline thereafter. So this is pre-treatment before we implanted the pipeline. The pipeline is implanted here. Cone beam is here. This is a follow-up showing the complete reconstruction of the bifurcation at that time. This is an interesting case. She was a physician that bled twice due to the giant MCA aneurysm. Was coiled elsewhere. Of course, the coils compressed, as you see, and she bled again. So she was referred to us. We put more coils. We stabilized the patient. We treat even her with for vasospasm with a double lumen balloon that we had at that time. Probably you recall the NeuroFlow, the coaxia system. We increased the collateral circulation with this. And after we implanted one single device, crossing, and this is the final result, more than 1 year follow-up, and she made an incredible recovery. Please come to Argentina, visit us. Those are our falls, Iguazu falls, beautiful falls. I know you have a Niagara Falls there, but this is really something that you have to visit. New device get into the field. Surpass was one of those. We have favored Surpass for a long segmental defect, as in this one, and the posterior fossa circulation. We close the contralateral vert, and we keep all the patient under heparin for 1 year. So this is the result at 27 months after that, after we implanted that device. The multi-layer cardiatis device has more than one layer. It's not two layer like a microvention FRED. It's multi-layer by 3D. It's going in and out, and it's a very good device. Has some surface treatment. That was validated in the University of Belgium. And the nice thing of that device, you can see nicely on MRI. We don't need, you will see the device, like no other device of other generation that you were not able to see that device. After that, we got the benefit of smaller devices, smaller catheters, smaller device. You can go distally. Of course, for so smaller artery. We did the first in human, the Fred Jr., that basilar tip that also was involved in the P1. This is 3 months of follow-up and 11-month follow-up. Again, you see some exclusion, some healing line that exclude the coils from the artery. So that experience was fantastic. PHENOX has the P48. The P48 goes inside of the 21 catheter. Is for arteries between 2 and 3 millimeters. Has an independent core wire inside. And in our experience, the morbidity and mortality is less than 5%. This is one bleeding case, very distal, and the perical also, and the conbeam you can see nicely. And this is another one that was implanted at the pica at the level of the dissection at that time. MRI correlates nicely. And this is the beauty of single VISTA baby, the smaller one that goes inside of the 16 catheters ID that we implanted at that time. So really, during those years, a lot of new things. But not only in flow diversion, not only in the endoluminal phase, but also in something that is called endosaccular flow disruption. We have some experience. I show you just briefly some example of intrasaccular flow diversion. Of course, we start with the web to do an intrasaccular approach many years ago. It's a fantastic device. We implanted the first one in 2009. I will show you some follow-ups. Today you have also 17, not only 21. So we went to that experience, was very good, fantastic. This is the first generation 21 MCA basilar tip. That one was a bleeding case that we treated at that time, 20 months follow-up, and this is a ophthalmic one to 22-month follow-up. So that was very old cases. We got the benefit of the good things, but also we saw some recanalization at that time. I show you the right MCA that was treated with web. There was some recanalization, so we had to retreat it with coils as we did, and this is the 15 months follow-up showing very nice results in that particular case. So there are many intrasaccular devices, Luna, Pulsar, that we have experience with Piconus, Picambas, and also we have an experience. I will show you a case with the Serus device, with the Contours device. This is a kind of half flow diverter system that target the neck of the aneurysm. It's just half of that. You have to compress nicely inside of the aneurysm. come with the pre-shaped structure, a self-anchoring. You can resheet it many times. And of course, you can detach electrothermically. This is the device in the picture. And I show you one case that we did in that bifurcation aneurysm. The key issues have seating that proximal marker at the level of the artery. And the device has to be implanted inside of the neck of the aneurysm. And this is a nice result at 15 months follow-up. You see with the combines nicely the device inside of the aneurysm. The P64 experience, this is a 19-old device that we use. This is 3 years follow-up. For us, it's 4th generation because you can retrieve many times. It's a mechanical detachment, proximal mechanical detachment. We had extensive experience. Today, 600 aneurysms treated. Those are the markers, the proximal marker that you detach mechanically. And those were the markers around that we had before. They evolved. The company now has the P64MW that comes with the surface treatment of HPC. The nice feature that they have is as soon as you start to deploy the device, you can move your guide back. So you know that feeling that everything moves inside of the brain with the 15 millimeters of the wires that you see and scare you. As soon as you start as soon you open the device, you can withdraw your guide wire. And this is something very, very nice. You can deliver it through a rebar extend. Those are DFT, so the platinum is inside of the nitinol. Just to compare, this is the pipeline, and this is in the same patients. This is the P64 MW, has a very nice radiopacity. I'll show you one case. This is the giant before we treated. It was a little bit difficult to find an exit, but we succeeded. This is immediately after treatment and 24 hours. We always perform 24 hours follow-up on those patients. And this, I believe I had here. Here's the combine showing the markers around, and those are the 8 proximal markers. And this is 11-month follow-up showing the nice positive remodeling of the device. Well, you know, those companies I acquired most of the time. So the Chestnut was acquired by EV3, the EV3 by Covidien, the Covidien by Medtronic. What we gain of that? Well, certainly Medtronic did a good job because they invest in the company. They came with a surface coating to decrease platelet activation, which I think is a problem. There are more now, more with surface treatment that we're going to have a brief view of that. But certainly there is a need for that. I try to convince the companies that we really need that. I must tell you that I was pushing hard, but it took me years to convince the company of the necessity. So the first coating comes with the shield technology on pipeline. Today, the PHENOX has most of his product has HPC, P64, P48, and Cardiatis also has surface treatment. The shield is very nice. Has a really low thrombogenic profile. As you know, the technology is a surface modification with phosphorine choline. It's a polymer that is bounded covalently, and we have used it extensively. Has been validated at the beginning by the Matt Gunius group. They show that those flow diverters are associated with less thrombus formation at the level of the device. And also, there are some groups that they have published his experience. This is a European study. This is our experience at 274 cases. This is a particular case that I prefer to use that. This is a lady that was sent from Thailand to us. She has had Ehlers-Danlos syndrome. She has a cavernous aneurysm, and everything down was dissected at the level of the bifurcation at the level of the neck. as you see here. We tried from distal to proximal, implanting, I can't recall, I think we implanted 5 or 7 devices, device in device, again from distal to proximal. This is immediately after the treatment, and this is 1 year follow-up showing very nice reconstruction at 12 months. Other type of what I prefer to use is a bleeding blister-like. This is a blister-like with a massive bleeding. They call us day 3. If you compare the first angiogram, the blister here, you see some thrombus problem here. The thrombus was partially absorbed here. The contrast going deeply here, there. So in those particular cases, I jail my microcatheter. I prefer to put a coil there, as you did in the particular case, and we did three shield over the artery. So what was our protocol? We used tyrofibam, agrastat in those cases inside the procedure, and we start loading the case with prasugrel right after. We keep on ticagrelol that patient. This is 3-month follow-up. I believe this is a MRI showing there is no thromboembolic, nothing in diffusion, and this is 6-month follow-up showing the complete disappearance of the vision. Another coating comes from, as I explained, from the PHENOX. They have a hydrophilic coating that inhibit platelet adhesion. That was it's interesting, the concept, because as you probably know, the endothelium has a glycocalyx. It's a natural lining inside of the endothelium. So the HPC hydrophilic coating mimics glycocalyx. So the platelets didn't recognize the endothelium and went through. That has been validated in several studies under electron microscope, as you see there, and also Matt Yunis did a UMass beautiful study showing that has less thrombus formation in his conclusion that if you combine with aspirin, and he did in the experiment, eliminates thromboformation at the level of the stent, and also at the origin of side branches. That product also has been validated in vivo and canines, and I show you one case that we use in the bleeding setting. Was tough to find an aneurysm here. You see, there's a massive bleeding around the basilar artery. As you can see there, some hydrocephalus. Was tough to find really an aneurysm after we find a very small one there. So we implanted a very small device, 3x15, and again, and the tyrofibam combining with ticagrelol. Here immediately, 1 week, you see the stagnation of the contrast inside of the aneurysm, and this is 6 months showing disappearance of the lesion, and there is no lesion at the level of the brainstem. We try to use in some cases aspirin like monoanti-aggregation, but it's very appealing because the cost is low. You have a low bleeding risk in case they have a problem. But I must tell you that it's difficult because there are multiple medical interactions, not only with medicament, but also with ICH, with the bleeding itself, with the stress, with the fever that we have in those cases. So it was very difficult. I don't recommend to do that. Other surface treated flow diverters. Bulk has the CD21. Which helps not only has less thrombogenicity, but also to has more speed up in the endothelization. I think it's an interesting concept. Microvention has the X coating, the X, which is another concept. But the stenting, the flow diversion without anti-platelet, I think is a dreaming that is chasing very far away, but we have implanted under mono integration with prasugrel several devices. Just to summarize, the thrombogenicity is clearly low and shield device and an HPC device, the push force that you need is clearly less in the piece in the shield and also in the thread. Complication, you know, I show you the nice things at the beginning, but now we have to go also the problems and complications. We had technical complication, we had clinical complication. We can rupture at the beginning, you know, the distal wire was a problem. So we rupture 3 or 4 of them. We rupture some bridge when you use multiple devices. I will show you one example. Sometimes you have to retreat those patients due to these problems. And the real problem becomes when you have a laser cutted stent implanted before. That's a problem. We will go over that back. Clinical complication. You can have thromboembolic event. We have more morbidity due to the thromboembolic event. We have more mortality due to the hemorrhagic strokes. And we have to give some answer to this question. Why do some aneurysms bleed after flow delivery? So this is some of the problems. As I mentioned, this is a case that we lost a wire. When we pull the device, the wire was ruptured. To the treatment, we tried to capture. We couldn't, so we leave it in place. This is 20 days after. This is 1 year after, showing the wire stayed there. So after some experience, we decide don't do any effort, leave the wire there. The patient is under dual anti-agregation, so there is no need to take the risk to pull, to do maneuvers to take out the distal wire. This is another problem. The rupture of the bridge or the dislodgement of the bridge can be a severe problem. We learn, as you probably from Maxim, beautiful in his web. You can explain a lot of things. You can explain. We blame sometimes the device. Sometimes we have to blame ourselves because we stretch the product. We unsheath too much. You know, the delivery of the PET is kind of art and science combined. You have to push and pull. Sometimes we just unsheath, and of course that happens after. A few weeks later, you will have rupture, you construct because you just stretch the device. So I show you one case. This is a case that was sent by John Barr. This is a severe segmental defect that comes from ACA up to MCA, as you see here. There's a very small and thin MCA, as you see here. Please recall, because after there was some instant stenosis here. So we did all the measurement. We succeeded. We implant 4 devices from distal to proximal, device and device. But I tried to accommodate the construct, you know, with the wire. I was massaging there, and during one of those massages, I ruptured the construct. So I had 2 flow diverters here, 2 flow diverters there. I tried to recapture, I couldn't. So I brought my alligator at the time. I captured the distal 2. I pulled down them inside of the aneurysm. I left there, and I started to reconstruct now from proximal to distal. Fortunately, I was lucky. I went to MCA, as you see here. You see the difference in between sizing. The distal clearly smaller and the proximal is bigger. So this is the distal situation. The patient was followed in the US, and they sent me the beautiful decrease of the sizing of the aneurysm. We were discussing here 3 months. They thought that maybe there's a stenosis here due to transient stent stenosis. So we decided to keep the patient on the anti-platelet for 1 year. At the 1 year, you see, there was no more hyperplasia at that level, and the patient went really well. So I strongly recommend to work a little bit, trying to follow the path of the Malbec. You know, we have a very, as you guys here there in California and Napa Valley or higher up, you have a good wines. We have a very nice Malbec. You have to have a nice wine glass, push and pulling, not champagne or not martini glass. This is something that is, I think, is very relevant and we learn with experience. So please try Malbec. Okay, so why you can fail with flow diverter? Well, there is evolving endoleak because you have a primary misdeployment due to the device malposition, and this is something very important. You know, I strongly recommend to do a combine. Make sure that the wall is very nice opposite against the device, because you have to coverage from normal to normal. This is very essential. Sometimes when you have PCA incorporated inside the aneurysm, you can have it takes really longer, or you will never occlude the aneurysm. And of course, if you have a laser catheter placed before, you will have a problem, as we have in these particular cases. Young male presented with seizure, you see the gliosis and edema around the giant partially thrombosed aneurysm that was treated with stent and coils before in 2005. 2009, the patient comes with a neck remnant. So we implanted first and second pipeline device, but you see, even with two devices, device in device, you see the neuroform that was implanted before, a lot of coils there, but still you will see the compaction here in between. The flows goes there because there is an endoleak there. Almost 8 years after, still contrast going in there. So what happened if you jail branches? Well, we have jailed many of those branches, big one and also small one. I show you one complication. Again, we have an infarction because we had a neuroform implanted before, and this basilar trunk dissecting aneurysm was treated before with neuroform and coils, and after we use a pipeline 275/12. We were very happy. We think we had everything done nicely, but the patient developed a brainstem infarction, as you see there. So, big question now. Who has an answer for that? It's very difficult to give an answer of that. Why very few of those? In my experience, less than 1%, but still a big complication. We saw the first one, or we report that back in 2011. We tried to find an explanation from the CFD point of view. Certainly, it's not. There are two mechanisms here. Clearly, one thing is the CFD, the flow, who drives the process, but the second is the thrombus and the wall of the aneurysm, the inflammatory markers there. So we must realize that most of those cases are very complex, and the natural history of those is tough. No, 80% of those complex aneurysms has morbid mortality in the next 5 years. But also, we must recall that we implanted, we add a second disease. We adding anti-aggregation to those cases. So, what are the solutions? Filling an aneurysm with coils and flow diversions, more than one anti-platelet test, control blood pressure. We have done everything. I must tell you that I have bleeding with coils and flow diverter. So we have done everything. How we can explain that? Well, if you think in the pathology, you can have hyperacute bleeding, as I show you one, because you dissect the aneurysm, or you can have an acute bleeding because you have some mechanical complication or valve, or so-called valve effect. But also you can have a subacute bleeding 1 week or even after that, because the inflammatory reaction due to the proteolytic activity. So some biological explanation. So remember that. This is a case that I was very impressed by that case. That was a giant segmental defect. We implanted only one device. Everything was fine. The patient was very fast. So I asked for the last injection. During the last injection, we got the rupture of the aneurysm and the posterior part of the aneurysm, as you see there, and massive bleeding, as you see, and we lost that patient. So it must be something in the wall. Lately, we study in extension. We have a Tesla with us in the same room. We combine biplane with the 3T. So we study at the wall of the aneurysm, try to see if there is some inflammatory reaction. If there is inflammatory reaction, we use coils and flow diverter. If there is no inflammatory reaction, we use only flow diverter. Also, we try to find an explanation from the hemodynamics with the so-called MAFA, try to quantify the flow inside and see if we need to add more than one device in the room during the treatment. But the most important thing is the learning of the pre-treatment planning. I think this is important. We abandoned the clopidogrel since 5 years now, I think 6 years now, because if you have a drug that it doesn't work in 1/3 of the patients, why you are keeping use that same drugs again and again? So we switched to prasugrel many years ago. And we, of course, we have some experience with ticagrelor also. The problems with the ticagrelor is you have to use every 12 hours. And if the patient forgot only one single dosage, you have a big problem. But this is our regime. We use prasugrel. We load 6 pills, 60 milligrams. We try to load 6 days in advance. If no, we load the patient with Agrestat, and after we start with prasugrel. So we are using extensively the Agrestat or the tirofiban. The other important and cheap thing to do is control the blood pressure. It has been shown by the Japanese colleagues that the most important factor that can grow and rupture an aneurysm is the blood pressure. It's something that we didn't pay attention until we had that complication. Today, we have a very strict and aggressive protocol developed by our chief of cardiology. We are very aggressive and very obsessive with that type to prevent the bleeding. So probably, as you saw, we have done a lot of work, and during those years, a lot of things have been improved. We have more experience. We have new devices, longer devices, better devices, surface coating, but still some work to do. In my experience, the flow diversion has been really a breakthrough that you compare with the coils. And the ideal flow diverter is something that will come. We didn't have the perfect one yet. We have to keep on surface modification, and we need clearly a new materials, or maybe we need some liquid metal. I will show you some of that. But we have to. You guys are younger. You can help us. We need clearly some innovation in the field. The people from I think Calgary have been shown that is a novel flow diverter. I think with a new material. This is a bioabsorbable one, so I think probably has some future. I'm sure that the impact of nanotechnology and molecular biology will help us to understand the clot maturation, which I believe is the key issue in that trip. This is the liquid metal in the middle, steel in the left, and nitinol in the right. You see, all of them were elastic at the beginning, but with the time being, the only one that keep elastic is the liquid metal. This is something that keep in mind, but because you will have a lot of that in the near future. So in conclusion, sorry because that was too long. I think the flow diverter achieves complete occlusion and rupture sidewall, and especially in segmental disease, has been a durable treatment and very efficacious one. I think one thing that it favors a lot was cost. I mean, the diminished cost, less coils, but especially the radiation issue, which is important for the patient but also it's important for us. The exposure has been dramatically drops in our hands. Of course, the new polymers and coating were found, and they inhibit in vitro and in vivo. Now they came from our helps. But I think I encourage you, young guys, to do more and more work. For us, it has been a tremendous experience. We help a lot of patients in our hands. But remember, the decisions in medicine are not that easy, like in a cooking stuff. You have to work, you have to combine science and art. So that's why I like very much the title of the talk. And remember, sometimes you have to change. Change is mandatory sometimes to get better results. And thank you very much for your attention.
Thank you very much, Professor. We're glad we had this talk. It was incredible for us. Dr. Cameron McDowell, the head of our department, is also connected with us. And thank you very much. Really, really good. So we have a few questions, many questions actually. You can try to answer as many as you can. First of all, what is your protocol management with the platelets function tests? What is your protocol in urinary?
Since thank you for the question. This is very nice. This is something that we understood with the time being. We since now 6 years, we do verify now in all of our flow diverters devices. We do, and I think we do believe that this is important. And we understand that when we are running out of products, what important it is. But yes, we do systematically. We do before the patient. We started with the patient, and we follow up the 3 months to 1 year. And it's incredible how we have to adjust sometimes the doses. I think the 60 kilos barrier is something important. If you have more than 60 kilos, I think that maybe you will need to increase your dose, or you have to add a third one. We have a hematologist with us that take care of that. She has a tremendous experience, Monica Tamashiro, and I tell you, she helped us a lot on understanding. This is something that we have to, you guys has to understand. We are working with blood, and the blood can be our best friend or our worst enemy. Regarding ticagrelol, I would like to make a comment on that, because it's easy, because it's fast, fantastic. As soon as you stop, it stops to work. But this is a problem sometimes, because you don't have a margin. In Latin America, the cost is also a problem. The ticagrelol is very expensive. The prasugrel is not. And of course, the cheapest one is the clopidogrel, but really we didn't like it. But yes, we are using systematically the verify now in our experience.
Okay, and in case you have a patient who is an hyper responder, how do you manage that?
Well, we had those cases. We had a complication of that. There are several ways to deal with that. I just recall one experience with the prasugrel. It's a fantastic thing, but in case you have a complication, it's very difficult to bring the patient to the operating room, because everything bleeds there. We manage in that particular case replacing platelets in those particular cases.
Okay, regarding the obliteration rates of flow diversion, there are many studies. For example, PETA and PAFs show like 95% obliteration at 5 years. The Aspire and Intrepid 75, and for example, your rates in the pedestrian registry is 95, if I'm not wrong. Where do you think that number is?
No, it's 95 after 5 years.
Yeah.
is close to PAF, which is a little bit higher. PAF is, I think, is 95%. But it's clearly related to two factors. One factor is the endothelial factor, the so-called positive remodeling. It's like you are creating a new artery. So after you created that new artery, you improve your occlusion rate. And I think this is very important. But has been a lot of controversy with that. I think people didn't pay attention that much to the value of a correct wall apposition. If you having your device floating in the middle of the artery, you never will have a complete occlusion probably. So again, our rate of 95% is after 5 years. In the first year, was approaching, I think it was 69 or 68% in the first year. With the time being, you really got a nicer and nicer occlusion rate, except in cases that you have you didn't have a nice wall apposition, or you have a branch coming off of the aneurysm, as I show you on the ophthalmic. The first case with the ophthalmic segmental disease with 4 aneurysms and the ophthalmic coming off, you see the shrinkage because in the periphery of the aneurysm, you will have a thrombus formation and most important, thrombus organization. To have that thrombus formation, the thrombus organization and the scar, you need time.
Okay. From the pedestrian registry, one of the exclusion criteria was posterior circulation complex aneurysms and fusiform aneurysms, if I'm not wrong, right?
Yeah, we had done very few of those.
And what is your experience with that kind of aneurysms?
Well, as anybody else experienced, probably Cameron has some experience. The rate of, we are talking different diseases here, because in the posterior circulation, at the beginning, everybody was very enthusiastic about treating those ugly fusiform hollow basilar aneurysms. We have implanted sometimes 7, 8, 9 flow diverters on that, and we got a lot of complication due to the perforatus occlusion. In the posterior circulation, I mentioned the protocol. We try to do we close the contralateral vertebral artery, and we keep on for 1 year in dual anticoagulation, and also on heparin those patients. And after, we keep those patients in Clexane, just to avoid the perforators occlusion. Right. Yes, but right, there are different diseases there. One thing is the saccular basilar aneurysm. Another thing is the hollow fusiform atherosclerotic aneurysm. And I think people got confused. We had good results on saccular. We don't have good results in fusiform holotasic fusiform basilar aneurysm.
Okay, Dr. McDougall wants to add a comment on a question.
Dr. Lylyk, it is so wonderful to have you with us, and I'm just in awe of your experience and what you've accomplished. You've been such a pioneer. I don't think there is a device that we use today that didn't first come through your hands and with your blessing. So thank you for what you have done for the field and how you've advanced it for all of us. It's an amazing experience. There's too many questions to ask in the time we have, but you've been such a pioneer. I'm just wondering if you could sort of philosophize a little bit about your experience. You've taken devices at early stages, enormously stressful, I'm sure, for some of these new devices trying to push the envelope. And I'm just wondering if you could talk a little bit about what it takes to do that, and moments of doubt you've had, that sort of how you were able to push through.
Well, thank you, Dr. McDonald. Really, really, I appreciate your comment. it has been a long way since I started at London with, one of the guys that pushed me a lot to do endovascular with Charles Drake. I always remember his comment. At a certain point, when I was ready to leave London, I asked him if I should keep both. I mean, keep doing endovascular and keep do microsurgery. And he told me that his thought was that probably the endovascular has more future. So he one of the push me to do endovascular. So when I went back from London to actually LA with Fernando, we took place, Anti-Platelet place at that time. I did only endovascular. I am glad that I took that decision because sometimes I feel that we push too much, but this is the way that the thing has been improved. As you said, at the beginning, everything was tough. Most of those were really prototypes more than a device, but more than commercially oriented devices. But with the time being, I saw enormous progress because also I saw the progress between the relationship between the industry and ourselves. And both learns, I think both extreme learns. Industry learned that there is frontiers that they have to respect, and we learned that we have to push them. It took me, as I comment, took me many years to convince that we need some platelets, some treatment on the surface of the device, because BPLR is very nice because you have a very nice result, but also you see the problems at the beginning. I saw the problems at the beginning. So I asked for help. I asked for the company to make longer because, also the bigger diameters, Even today, I am pushing them to have flow diverter bigger than 6 or 7, or flow diverter for bifurcation aneurysm, because they have to understand that we are not tubes. We are not uniform tubes. Sometimes I discuss a lot with engineers because they come with a model, and the human being is not a model. Well, the best human model is the cadaver, but it's not very good. So I push a lot. I enjoy working with industry, but also working with engineers. I think working with other people's opened my mind. And also going to different meetings. If you go to the cardiology meetings, but usually, the cardiologists learn from us, but I also learn a lot from cardiology. I was lucky, I was working with cardiologists in our team. I learned a lot, especially in the ischemic field. I learned a lot. So going out of the box, taking your head out of the box, you learn a lot. And that was the way that I really improve, and I push everybody to improve. I push my teammates, I push the industry, I push the engineer. Probably I'm a too pushy guy, but that was the way that I think we improve, guys. We combine art and science. I like very much the title of because this is, I really believe that we combine. We medical doctors are artists also, not only scientists.
Yeah, that's wonderful. I fascinated to hear you mention Dr. Drake, because I think it really is underappreciated how much of an advocate he was for endovascular and how influential he was in getting it started. So that's very, very interesting to hear you say that. How far are we going to go with flow diverters in how small vessels? We're looking at the pericallosals and those sorts of things. What's your limit for the smallest diameter that you're putting flow diverters into?
Well, the BALT system, which is the smallest, goes through the 16 catheter, and you can target sizing between 170, 175 diameters, and the artery, the smallest one. But of course, it depends on many things. I have been treated M2, M3 dissecting aneurysm. I have been treated far more than callosal marginal also. In the posterior circulation, I target P2, P3. To today it depends of several things, as you know better than me, how much support, other thing that has been changed a lot our life. Remember in the beginning, we teach our fellows to stay with the intermediate catheter below the cavernous sinus. I was blaming them because they come with the catheter higher up, but today everybody comes with a 72 catheter ID M1, M2. So we not only gain on flow diverters, but everything else has changed a lot. The microcatheters, the gliding inside the guidewires. I mean, lot of improvements. So if you have a nice support and you have a stable position, you can really go outside. Another limit that we have sometimes is also try to find the way to bend it, to bend the guidewire and the microcatheter to reach it more distally, because sometimes you have very acute angles. So that also will help us, because now with the new catheters, the bended catheter, everything will change, because now you can turn left, right, anterior, or posterior. So, but you must judge use your clinical judgment to go how far you can go. It seems like we don't have limits, but we have limits. And the limit is the safety of the patient.
Have you seen more in-stent stenosis become a problem in those smaller arteries?
Not really. No, with the longer follow. I have more than 1 year follow-up. No, not really. But I am very aggressive with the antiplatelets. I am in the anterior circulation at least 6 months, and the posterior circulation a year. I have been very aggressive, because this is a phenomenon that happened. I learned that from cardiology. That happened between 3 and 6 months, but there is no clock inside the brain. So sometimes it can be 6.5 or 7 or 8. So I learned that we have very conscious on that. That's why I insist to the company that we need to have only many mono aggregation instead of have dual risk, one risk. So there is a lot of room to improve that.
Okay. I don't want to impose on your time there. I know Matthias has more questions. I don't want to monopolize it, but I would like to just squeeze one more question in. What in the larger aneurysms where the branch comes out of the aneurysm, you put a flow diverter in, the aneurysm shrinks down, but there's residual aneurysm because of that branch coming out of the aneurysm. What do you tell patients their degree of protection is, because they're always, anxious if there's residual aneurysm? Do you feel they're fully protected? Have you seen those rehemorrhage with delayed follow-up? What are your thoughts on that?
Well, we learn in the bad way, because the beginning maybe we were very positive. We thought that everything will be cured. With time being, I learned that we have to be very conscious with the patients, because simply I don't know. There are some answers that I don't have at the end. So in those particular cases, I advise him that he's going to the process, the healing process, and sometimes I don't have control of that healing process. I think that will change. I think that everything will be okay, because the PL circulation will take over of the shrinkage of that artery. But you have to be honest and with the patient and tell them that there are things that we don't know. Simple like that. In the Faculty of Medicine that teach us that we have answer for everything. It's very difficult. The most difficult thing in the science is to have answer. So we have to be modest and understand that.
Learn to live with uncertainty. I want to thank you, not just for today, although I'm enormously grateful for today, but for what you've done for us and for our field. It just really wouldn't exist as it is for us today without your work, and I'm just so grateful to what you've done for it. I'm going to just turn it back to Matthias, and I know he's got a few more questions if you have a few more moments.
Yeah, thank you very much. Thank you for your comments. Hope you see you soon.
Yes, that would be wonderful.
So Professor Lylyk, a few questions from the fellows. First of all, how do you select the size of your flow diverter? You oversize, what is your thought process?
No, I am trying to be one-to-one. I only oversize when there are perforators nearby. Let's say there is you're working in M1 and there is a lenticular strait coming out from there. So the first device that I implant distally, I oversize a little bit just to be. I prefer to wait a little bit more for the occlusion, but be more safe. But again, I learned a lot from the CFD. I learned that I need to occlude more than 90% of the ostium to occlude that. But who knows you are going to occlude or not. I think a lot of things Cameron will help also, will change now with the HD OD, with the endovascular image. I saw a fantastic work on that experimental work done with OD, and that will help a lot of us, especially to see if there is thrombus or no inside the device, because with DSA, we don't know that really. We maybe sometimes think that there is no thrombus, but sometimes the OD has been shown that there is thrombus there inside. Also, so that will be the endovascular image will come soon to our help, and that will be a fantastic help for us.
Thanks. I understand that you don't like to put you try to keep minimalistic with the number of flow diverters, but is there any situation in which you try upfront, that you will put multiple devices?
Yeah, well, it has been two stages in my life. In the beginning, I was very aggressive because I learned from Kim Nelson, and Kim Nelson teaches us that we almost have to construct very nice device with many. But after that, we start our experience with less devices, and at the very end, we got very nice results. So yes, I changed that when I see that there is one. I finish up and there is one vector that goes straight to the wall, and one single square inside of the wall pointing up, and all the flow goes there. So in that cases, I put 2 or 3, even 4 devices, and in some cases of that, if I feel that the aneurysm can rupture, it's very difficult to explain that with experience. How the behavior of the flow inside. One thing is circulate and goes away. Another thing is you concentrate every single power in front of you. In that particular cases, I use more than 1, more than 2, more than 3. Try to divert the flow from the artery if I perceive that there is a risk for hemorrhage.
Okay, for the fellows, let's say we deploy a device and we see that the aneurysm is thrombosing very fast. What are the immediate management considerations?
This is another thing. The cases that we saw the rupture, there was immediate occlusion. There was a cascade of beta proteinase, all the enzymes there. So I don't like that. That's why this is another reason, because I prefer only use one. So I give time for the interchange between the artery and the aneurysm. Flow goes in and out. If I perceive that there is a complete occlusion, first of all, this is another time when I use more than one, try to make sure that is completely blocked, and I am adding Solumedrol, 3 or 5 doses of Solumedrol, 1 per day to those patients. Try to diminish the cascade, the protein cascade on those cases. I am using absolutely steroids on those cases.
Okay, and one last question. Do you have any experience with flow diversion in carotidocavernous fistulas? And do you use any adjuvant transarterial or transvenous?
Yeah, well, like anybody else, I treat some of them. My experience was mixed. I achieved 50%. I think I have I'm not sure, but I think I have six cases. 3 went well, 3 didn't. So I approached them finally from the venous side. I'm doing a lot of venous approach. We learn a lot because we are working on the next revolution of endovascular surgery, of treatment of hydrocephalus. So I like very much the venous approach, but was kind of mixed sensation. I had cases that succeed, 50%, 3 cases, but also have 3 cases that I couldn't occlude the fistula from the arterial side. I never try from the venous side using flow diverter.
Okay, Professor Lylyk, it's been an honor for us. Really, we appreciate your time and expertise and everything. We are delighted to have you, and thank you very much.
Listen, I hope we can have you back to talk about the venous revolution.
Yeah.
Yeah. Well. Yeah. Whatever we have done 5 cases so far, and now we're starting our protocol MPH. Those cases that we did before, we use we treat hydrocephalus from bleeding, from subarachnoid bleedings, but we're now ready to start our protocol in NPH. So I'd be delighted, guys. Just invite me. I'd be delighted. No problem.
Of course.
Thanks again so much. Wonderful seeing you.
Thank you very much. Thanks,
Thank
Professor.
you.
Bye.
Bye. Thank you.
Thank you.